Good evening, everyone, or good morning, as always we say, because we say hello to the whole world and to whole and the family. And today I have a huge pleasure to host in our ESC live studio very well-known personality, worldwide known, recognized speaker and educator, Dr. Maciej Zarow. Hello, Maciek. adding you to
Hello.
into the studio. Hello, it's
Nice
nice
to
to
meet you,
see you.
Laura. Thank you very much. You pronounced my name as a Polish person completely, so you are you are not pronouncing it like a foreigner. Very good.
Okay. I just want
Congratulations.
also to add, thanks. I just want to add also our ESC COO, Monica Freire.
Hello,
She will
everyone.
be working, she will be working in the backstage and she will be collecting your questions and some comments or whatsoever. So please join us because today we are going to talk with Maciek about Endo-Resto topic. And I think this is very important topic and very interesting one. So I just want to introduce you very shortly. And as I told you, I have a bit of challenge because yes, you have two specialties. You are restorative specialist and you are endo specialist. Am I correct?
Yes, let's make it that way. That in the past in Poland we were doing the two-step specialization. So I did a specialization in a restorative in a general dentistry, but then I took a chance. Then the specialization were changed, and then I take
Yes.
a specialization in resto and endo. Remember, in Poland, we'll talk about that, but in Poland we have
Yes.
not separate endodontic specialization, but
Yes.
it's
Yes.
like resto
Like
and endo.
connected. Yeah, so we will talk about this because we have some differences in different countries, yes, about the specialization, and that might be a problem regarding your topic, yes. So you are endo-resto specialist, and you are an author of more than 8 publications, scientific articles, I think, yes. And you are also an author and co-author of 2 books, Endo-Resto and Veneers, yes.
Yes, exactly. 2 books and many scientific articles, something like
Yes.
100 articles. But that's
Yeah. So we have to.
normally when you do PhD and you continue your curriculum, you publish. And if you want to publish books, you need to write the articles because you need some backgrounds to write it from. So it's nice to write articles in order to summarize them in the book. Definitely.
Mhm. Yes, and you also you are an organizer. You are the host of the international, I think, yes, event like a dental spaghetti in Krakow. Yes.
Yes, Dental Spaghetti is our event that we organize in Krakow, amazing city of Krakow, the heart of the Europe. And
Mhm.
it's in the middle of Europe, because Krakow people from Krakow are very, very proud of their city, which is very old. And Dental Spaghetti, yeah, it's a congress that we organized first in 2001, and with the break of COVID, we organized it for 21 times. So this is a very strange
Amazing.
name
Mhm.
with influence of Italian dentistry that influenced ourselves and myself personally at the beginning of
Mhm.
21st century.
Yes, and you will be the speaker of ESC autumn meeting.
Yeah, that
But
will be
ESC
honor.
stage is not nothing new for you, yes? Because I found that old photo, not so old photo from Barcelona when you was heading to or from the pool, and I think it was just before your lecture, and I was like, oh my God, he is going to the pool just before his lecture, or that was after your lecture. That was very funny, but it was
I don't remember. I think before my lecture, so before my, but it's a good thing
probably
to
before your lecture, yes,
from my
because
lecture.
that was so surprising for me.
Yeah,
Cool.
it's a good thing to have
Yes.
some relax or sport or jogging or
Yeah.
swimming or whatever and especially if you remember that pool was on the terrace. It was a beautiful
Of
weather
course.
in Barcelona. I don't
Yes.
remember 2014 or 15, but it
14,
was
14
for
probably.
yeah,
Yeah. Oh,
amazing,
yeah, or
amazing,
maybe 15. Yes, yes. But
amazing.
anyway, it means that you are very confident because you know the topic and you can just have a relax just before your lecture. So yes, so let's dive into Endo-Resto topic, okay, Maciek? So yes, first of all, I want to say that there will be the whole session that will be dedicated for the obturation, and three more speakers will be talking about probably more about the root canal obturation, and only you will be talking about the Endo-Resto obturation, and as a single visit, single appointment issue. And I would like to start questioning you, asking you. So the endodontic treatment we often define like instrumentation, disinfection, or hemomechanical instrumentation, and then subsequent obturation. But usually we talk about the root canal obturation or the root canal system obturation, but we miss this very important link as final restoration. So this is, we all know that this is very, very important, but somehow we just forget it. What is your opinion about this, Taylor, to understand that the endo should be, or maybe not? Just give you your opinion about how much is the final restoration or post-endo restoration is important for the overall treatment of endodontic cases.
Thank you very much, Laura, for the question. For me, as a person who was doing for a long period endodontics, as is still doing, and it's also connected to resto, I think Endo-Resto it's a one thing for me. At least post endo restoration, and for post endo restoration, I consider or core build up, or I consider fiber post. That is in my opinion, it should be definitely performed by the endodontist. In my opinion, it would be much better, because for many years, for example, if I'm looking at my career, I'm working since 25 years in microscope, and only the endodontist who works in the microscope understand very well the anatomy of the root canal system, which is very complex, and also understand very well the particularities of the structure of the endo treated tooth. Sometimes the structure is compromised, and especially when it's compromised, every intervention in endo treated tooth, it's additional task and additional risk. So we should talk about risk assessment. And when the endo treated tooth is treated by endodontist, and he takes, I don't know, 1.5 hours to perform endo retreatment of the molar, for example, it should be so easy for him looking at in the microscope, and after performing the X-ray and confirming the quality of the restoration and the obturation, it's so easy to finish that with the core build-up made by the composite to perform the adhesive dentistry, or to place a post if necessary. But today we put less and less posts, because we know from the literature that the most important is a tooth structure. So I think I would consider the endo restoration as a one appointment task for the dentist, and I would really would love to place that task for the endodontist to perform it. It's much easier, less risk, and it's a big pain for the prosthodontist to go into the root canal treated teeth when they don't know anything about the root anatomy. and they never
Mhm.
looked into this tooth before. So they know the X-ray, and remember the X-ray is 2D. It's not a 3D view. It's very difficult to understand something from the X-rays and restore
Mhm.
the endo-treated teeth.
Yeah, that's a problem probably exists in some countries, like for example in Lithuania, we're very specialized. So we have two separate specializations, as I already mentioned, like endo and resto. These are very separate, and we always have uh, like a talk between two specialists who has to do and what. And usually some resto guys, they are pointing into us endodontists, and they are saying you should perform the core buildup or the final restoration, let's say, because you know what is going on there. You did this, so you know the situation, you know the case, and the cases can be very very different. So
And
uh,
it's also another thing sorry to interrupt you, but
no.
performing that and the single appointment, we decrease also the risk of the reinfection. So
Hmm.
every using temporary restorations, we risk that we don't see the patient for a longer time that maybe it's supposed to be. That's one thing. And second thing, we risk with losing the adhesion. So once we prepare the dentin, we can adopt appropriate bonding system and just close the endo-treated tooth with the restoration. I don't think about the crown. I don't think about the final restoration, but at
Hmm.
least the foundation, the core foundation. It's so important
Yeah.
to decrease the risk of the reinfection. So I think it's important.
Yeah, it's very important. Yes, because actually, as a referral doctors, for example, we when we receive just endo patients, so we are referring these patients back to the referral doctor, and again, we don't know the level, the quality of the treatment. So actually, we expose the root canals already treated, and we don't know if they are using the same standards, if they are using rubber, if they are using some kind of protection from. It's a very serious point. Yeah. So how do you organize this and the rest of flow in your practice, in
Oh,
your
in our
personal
practice,
practice?
yes. If you're talking about myself, I do and my practice, because I have a few specialists. Actually, in our dental office, we run specialization of Endo-Resto discipline. So
Hmm.
we are able to have two people for 3 years, and actually we taking only one, because but according to the law we can have two persons in our clinic to be educated as an Endo-Resto specialist during 3 years of education. However, we try to teach people, and we try to finish at one appointment, so make a single appointment endodontic. Of course, it's not always possible. You need to have appropriate condition to finish the endo. But if we finished already the endo and performed the X-ray, the next step is a cord build up, so we can clean the orifice of the root canal system. We use the sandblast or aerobrasion, 27 micron particles aluminum oxide, to clean it perfectly well. Uh, and if you have a microscope, you know that in microscope you have a completely different view. Even if you compare with the loop magnification is not the same. The
Hmm.
microscope is something unique which is used by the endodontist. He is able to see any cracks, any possible a risk that can be in this risky structurally compromised tooth, which is endo-treated tooth very often, and finishing that with core build-up composite. We have today very nice materials, sometimes fiber reinforced composites, which are applicable to place them in layers of 4 up to 5 millimeters. So it's quite easy for the endodontist and for ourselves to finish that with the. It's only additional 20-25 minutes to finish with the core and decrease the risk of the future contamination.
Yeah. So one more question. We as endodontists, we can treat almost everything. Yes, we can. With current technologies, we can take out broken files. We can bypass. We can take out the materials and so on and so on. The instruments are flexible. We can really have very challenging cases and manage them very nicely. We can see all those cases on the Instagrams and Facebooks and so on, nice white lines and something like that. We also talk a lot about saving the teeth, yes. And yes, usually the endo treatment is not done on the perfect, nice, intact tooth. It's usually broken tooth because of the caries. Sometimes we have already existing restorations, sometimes failing restorations, and sometimes, and quite often, we have badly broken teeth. Could you define the main factors that we have to consider as endodontists before the treatment that are very, very important in terms of restorability of this tooth and the future of, let's say, treatment of this tooth and its prognosis? What about the thorough or some more important factors?
Yeah, they are. Thank you very much for this question, Laura. It's indeed very important before we start to deal with structurally compromised tooth. We have to understand first how important is this tooth from the reason of the treatment plan. What will be the role of this tooth in the future treatment plan, and what is the structure, and what is the status of the structure. So is it risky? Is it very risky, or is it is mission impossible to restore? Of course, we need a ferrule. We know that ferrule, it's a supragingival structure of the tooth, which should be at least 2 millimeter high and 1 millimeter width after the preparation of the crown. Today, of course, we have BOPT preparation, BOPT, which is very limited structurally preparation of the tooth for the crown. It can limit the risk of the final tooth structure removal, so that's a good news. But still, we need at least this 2 millimeter height, which is at least from the lingual and from the buccal wall. This is the minimum that we need to have. And of course, when additionally we have to remove the old post, old instruments, probably we risk additional structure removal. So for sure we will not add structure, but we will remove some structure, although we are working in the microscope. So structure is one point. Second point to consider, it's a position in the tooth arch, and what will be the role for the future. Will it be, for example, if we consider that as a support for the bridge, that can be a problematic support for the bridge, because the tooth without ferrule cannot support the bridge anymore. So we have to consider the treatment plan. Sometimes we have to also to consider the occlusion, and we have to consider for example, lower the occlusal surface for the future prosthodontic restorations that we plan for that structurally compromised tooth. Also, there are some points which are beneficial from the point of view of saving the tooth. For example, there are, if the patient can consider the implant planning, fixture plannings, because sometimes due to not only economical reasons, but from the such a point of view like phobia, dentophobia, or from such a point of view like general health condition of the patient, he is not able to place implant anymore. So for such a patients, leaving even structurally compromised tooth, even without ferrule, can be beneficial sometimes. And after considering all this point, we can discuss with the patient, because finally the patient is a the decision making person.
Decision making.
We are the advisors. We can help to decide. We can talk with him, discuss all the points, but after all, the patient has to decide about the final decision to leave or extract the tooth, or retreat it and save it, even with the structurally compromised structure.
Yeah, thank you. And my last question, I actually just trying to provoke you to tell what are you going to talk in your lecture during the Krakow meeting. I don't want you to put all your cards on the table, but maybe you can point highlight the main points that you are going to cover in your presentation.
Okay, so because our conference this year is dedicated to the guidelines, so I will try to divide the lecture into the two type of guidelines. The one will be the guidelines according to the literature reviews and about scientific guidelines, and the second will be practical guidelines. So I'll try to prepare some video and very practical tips and tricks for the practitioners, because there are people who are spending most of the life at the universities, and they are doing a lot of research, and there are second type of lecturers that are staying in the practices, taping video and talking about tips and tricks. And I belong to this second
The
type of the
second one.
lecture, although I still do research and I love research, so everything will be evidence based. But I will talk mainly about tips and tricks in the restorations and closing the orifice of the root canal system, considering also the sealers, considering what type of materials is inside, considering the history of the previous restorative materials and endodontic materials in the canal. I will try to advise about the best possibilities about this core restoration and the root canal system restoration. So I'll try to make it as much dedicated to the endodontics as possible.
Wonderful. Thank you, Maciek, for dedicating your time already now. I am asking to join us Monica. Monica, you collected some questions or some remarks or some comments. We are waiting for them.
I have here one question from Inessa Petrenko, who is asking, would you seal the orifices of posterior teeth before the composite core placement, for example, with glass ionomer cement?
Yes, as I said, if possible, I would finish everything within the one appointment. But if it's not possible, I would place Teflon tape or whatever when I'm finishing the restoration and I'm referring it to the restorative dentist. I would place definitely glass ionomer in a thick layer. It would be for me the best to have a resin modified glass ionomer, because I never know when the patient is going to make the final restoration. So in my opinion, this thickness of the glass ionomer should be at least 2.5 to 4 millimeters, in order to withstand occlusal mechanical forces. And also, that sometimes, or in most of the cases, we adjust the tooth to the occlusal conditions. So sometimes we think it's 3-4 millimeters, but after occlusal adjustment, it's only 1.5 millimeter. And for that reason, the pure glass ionomer cement doesn't work that well as a resin modified cement. So I would use resin modified cement as a temporary material, which can serve as well as a long-term temporary material as well.
Okay. And I can see one more question.
One more question from Yared. Yeah.
Yes.
Asking, will the use of posts be addressed as well?
Probably in your lecture.
In my lecture, yes. Actually, my scientific research from the last years is about the fiber post in a upper premolars. I know it's a very controversial topic. However, I can tell you that I'm using personally fiber posts in anteriors and premolars in a situation when we lose more than 50% of supragingival tooth structure. So in this way, we can have a kind of support for the future crown. We can have a better stability, and of course, we need tooth structure. If we don't have a ferrule, fiber posts are useless because they cannot withstand the occlusal forces, and we can have a problem. So I will talk about that. And personally, I still use fiber post in a very specific cases, not that much like in the past, but I still use them. I don't know if that's okay with this answer.
Yeah, thank you. So I just want to remind that your lecture, the topic of your lecture will be Endo-Resto obturation in a single visit appointment. That's what you are going to cover. And three more colleagues who are going to talk about the obturation. So will be Stefan Simon. He will talk about bioceramic sealers. Are they predictable fillers for the root canals? This is quite important, I think, question.
Complex.
Yeah, it's
complex.
Yes. Yeah, and Josette Camilleri, she will talk about reality versus Instagram. Also very interesting, I think, to listen to her. And she is a guru of bioceramic sealers, and probably she will make a great overview of the new scientific findings. And Leo Teaderheine will talk about obturation. Should we know more? So he probably will talk about the research methodologies and some problems that raise for the researchers and with their outputs and their recommendations for us practitioners. So thank you very much, Maciej, for your time today. And
I can only say I really invite you to Krakow, because it's a great place. It's a great place historically. It's amazing place to hang out with, beautiful restaurants, a lot of young people, 200,000 students in Krakow, and especially in September we'll have a lot of sun, and both scientific program and social program. I'm sure it will be amazing to host you in Krakow.
Yeah, thank you very much. And thanks again for your time. Thanks to everyone who is watching. And we are going to make another live with another speaker. So we will have more sneak peek into the program, the scientific program of the Krakow meeting. Stay connected, stay tuned, and see you very soon. Thank you, Monica, again for your support, and have a relaxed evening, everyone. See you.
Thank you.
Thank you so much.